Good morning. My name is Aung from Singapore. I'd like to thank the AGS for inviting me to give this talk, as well as for awarding the AGS International Scholar Award. My talk today is on PACS, no PI. I have no disclosures. Ankylosing glaucoma is an important form of glaucoma worldwide, especially in Asia. There are several stages of the disease process, starting with angle closure suspects to primary angle closure and finally primary angle closure glaucoma. In the past, the progression rate from PACS to PAC and PACG was not clear, estimated to be around 30% over 5 years. The prevalence of PACG in many Asian populations is around 1 to 2%. However, as many as 5 to 8% of Chinese people above the age of 40 years are PACS. This suggests that most of PACS do not progress to PACG. Let me go through a case, a 59-year-old lady with hyperopia of +2 diopters. She has 20/20 vision in both eyes, a very mild cataract and shallow anterior chambers. Her intraocular pressure is normal, optic disc and visual fields are normal, and gonioscopy shows appositional closure, and this is confirmed on the Visante anterior segment OCT. This is a patient with asymptomatic PACS or narrow angles. So how would you manage this lady? The options are laser PI in both eyes, pilocarpine, bilateral phaco, or observation. Probably most of you will choose either laser PI in both eyes or observation. However, if we choose observation, we worry that we may miss a patient coming back with acute angle closure or chronic angle closure glaucoma in the future. These are blinding conditions. Laser PI is done in angle closure to prevent pupil block. It prevents progression to chronic angle closure glaucoma. However, there are adverse events of laser PI, such as visual symptoms and corneal damage as well as cataract progression. So how do you counsel your PACS patients for laser PI? Should you advise them to do a laser PI, or is there an option of observation and not doing a laser PI? Recently, there have been two major trials that have been done to address this question. First was the Zhongshan Angle Closure Prevention Trial, or the ZAP Trial, published in 2019. In this trial, they recruited almost 900 patients who had bilateral PACS, and they were randomized to laser PI in one eye and no treatment in the fellow eye, and followed up for 6 years. The primary outcome measure was incidence of primary angle closure, defined as 2 IOP measurements above 24, or the development of 1 clock hour of PAS, or an episode of acute angle closure. In the ZAP trial, the mean age of participants was 59 years. There were more females than males, and most of the iridotomies were placed superiorly. The follow-up was good, with 75% of patients completing 6 years of follow-up. And overall, the study ZAP trial found that the incidence of primary angle closure on the endpoint was 4.19 per 1,000 eye years in the eyes that underwent laser iridotomy, and 7.97 per 1,000 eye years in the control eyes or the untreated eyes. This was significant. A primary outcome occurred in both eyes in 10 participants. In raw numbers, this translates to 2% in the laser group versus 4% in the no treatment group. And the acute angle closure occurred in 3 out of 8 out of 89 cases, or 0.003%. The risk factors for progression in the ZAP trial were eyes with narrow angle width at baseline. So the ZAP trial results were a bit surprising in the sense that the progression was overall very low, less than 1% per year, and performing a laser iridotomy reduced the risk by about half. Laser PI was safe with no long-term adverse events. Remember, the primary endpoint was the incidence of primary angle closure, particularly the development of PAS, and there were very few cases who developed acute angle closure or primary angle closure glaucoma. So PAS by itself is not associated with vision loss. So the ZAP trial recommended that patients with PACS can be observed because the risk of progression is low. However, acute angle closure can occur in rare cases, especially with pupil dilation. The ZAP trial was, of course, a Chinese population, which may be considered as a slightly higher risk population. In other populations, the risk may be even lower. The ZAP trial also had a slightly younger population, about mean age of 59 years, and this is because they wanted to recruit patients who did not have significant cataract. It was also recruited from a community setting in China. The Singapore trial of the ANA-LIS trial was a sister trial of the ZAP trial, And in this trial, we recruited about 480 patients and followed up for 5 years, again with a similar trial design of laser PI in one eye and no treatment in the fellow eye. In the Singapore trial, we found that the progression rate was slightly higher than ZAP. 9% progressed in the no PI group versus 5% in the LPI group. Again, the risk reduction was about half. And the majority of those who progressed again was PAC. And the incidence of acute ankle closure was again very low, only 3 out of 480 patients. The risk factors for progression in the Singapore trial were narrow angles at baseline, higher baseline IOP, higher post-dilation IOP at baseline, as well as patients with diabetes mellitus. So putting the two trials together, you can see that the progression rate really is quite low. If you were untreated, it was about 9% in Singapore versus 4% in the ZAP trial. Why the difference between the two trials? Well, Singapore is slightly more multiracial with a few non-Chinese participants. The Singapore study also were recruited from a hospital setting compared to the ZAP trial from a community setting, and the angle width at baseline was slightly wider in the ZAP trial. So how have these trials affected management of PACS? Well, it gives us good evidence of the low risk of progression. And as I said, most of the endpoints were PAC, and certainly raises the question of whether we are overtreating PACS when we recommend LPI for both eyes. Right now, I discussed with the patient the options of either laser PI or observation. I quote the new trial data and explain the risk of both options and let the patient decide. For older people with cataract, I would recommend cataract extraction, and there's no need for a laser PI. So who should go for laser PI? Well, among those with PACS, I would recommend laser PI for those who are possibly symptomatic or having intermittent acute attacks, those who require regular dilation, especially those with diabetes, perhaps people with poor access or unable to follow up, and maybe people with a family history of angle closure glaucoma. So in summary, today I reviewed the options of observation only in patients with PACS. Both the ZAP and Singapore ANA-LIS trials showed a low risk of progression if you leave the patient untreated. However, I suggest discussing the risk with the patient and let the patient decide. In patients with cataract, we would recommend cataract surgery. I'd like to acknowledge my collaborators Ming Guang He, David Friedman, and Paul Foster, and the Singapore team who were involved in the ANA-LIS trial. Thank you for your attention.